And there we are. Good afternoon, everybody. Hello, I see already Hannah from the UK coming in. I would like to welcome you all to this second series of Global ScarS Society webinars. And I would like to ask you to do as Hannah just did and to let us know who you are and from where you are watching us. Also, yes, Hannah from the UK, and let's see who else we have here. I would like to explain a little bit that you can also ask your questions during the lectures that you're going to hear in just a minute. We will see these questions and we will be able to answer them. The lecturer will be able to answer them during the Q&A session immediately after the lecture. So make sure that you ask your questions during the lecture and we will be able to answer them. Some information on the Global ScarS Society, and I see a lot of people coming in, Laura from Cambridge, and Maya Vedamurti from the US, Andrea from Brazil, Jocelyn from Dubai. Welcome all to all of you. Some information on the Global ScarS Society. Last year, we published a textbook on scar management. And if you're interested in this particular subject, then I would recommend that you go to the website and have a look in this book, because you can actually, it is an open access book and you can freely download whatever chapters you would like. We see Cindy from the Netherlands and Ibrahim also from the Netherlands. Lots of people coming in now. Make sure that you add in the comments who you are and from where you are watching us. Another announcement is that in May this year, we will have the Yuma and Journée Cicatrisation Conference in Paris. And for once, this will be a live event again. And we sincerely hope that we will be able to meet with all of you by then. So please make sure that you go to the Yuma website and look at the program there. The special Global ScarS Society symposium will be on the 24th of May in Paris. So have a look at the program. And then one last announcement, that is you can subscribe to these interactive webinars on the YouTube channel, and make sure to do that. I would like to welcome also Saud from Pakistan and Viviane from Switzerland. Lots of people coming in, but I will start now by introducing the first lecturer of today to you, and that will be Marianne Altomare, and she has joined us from Brazil. Welcome, Marianne.
Thank you, Esther.
Marianne is a physical therapist, and she has a master also in human and experimental biology. She is also the CEO of her own Marianne Altomare Institute and a member of the European Tissue Repair Society, with whom we collaborate for a long time already. And in the last 22 years, she has been studying therapeutic possibilities, and that is also the theme of today. Scar management is that in the fingertips, and Marianne is going to highlight this particular part of the title of today's webinar. She is an expert in manual mechanomodulatory therapy, and the title of her talk today will be Manual Scar Management Techniques. And I'm really looking forward to hear your talk, Marianne. Please go ahead.
Thank you, Esther. First of all, I want to tell that I've been following the group meetings since last year, and it's really an honor for me to be here today. So thank you very much for the invitation. Well, to start talking about treatments, we have to talk about the physiology. We must remember that the physiology will guide all the therapeutic approaches. So we must stay very, very updated. And speaking of scarless healing, we know that adults heal through repair, not regeneration. And so the suggestion treatment is to mechanical offload. To get close to scarless wound healing, we have to pay attention to the tissue load. And speaking of mechanical offload, we have to talk about tissue mechanobiology, so us can understand a little bit more about this all of mechanisms, and also the relationship between extracellular matrix, the myofibroblasts, and the fibrosis formation. Scar tissues are formed due to the damage, depending on depth and extension. The new tissue is produced to fill the gaps left from the trauma. So we know that scar tissue deposition in larger areas will have more tissue to fill the gaps, and also exacerbated inflammatory response. Inflammatory response also exacerbated proliferation. And with all the collagen fibers, we will have mechanical overload, and this mechanical overload will get us to fibrogenesis. When we have fibrogenesis, we also have the apoptosis delay, and with no apoptosis, we have no remodeling. And this can last months to years. So we can say that the cellular and molecular mechanisms to fibrosis formation are due to the presence of myofibroblasts, the activation of TGF beta 1, and the apoptosis delay. The tissue mechanobiology is important to all metabolic process, and it involves mechanical loads that modifies the structure of all living tissues through mechanotransduction. And this mechanotransduction will affect chemiotaxis, angiogenesis, and also activation of the myofibroblasts, and so the extracellular matrix production. And this myofibroblast contraction will activate the latent TGF beta 1, and when the matrix is resistant, and with the matrix resistant, we can figure out what happens when we have scar tissue, especially in fibrosis, where the collagen content is higher, increasing even more the matrix resistance. So one good thing to do is to reduce the tissue tension to stop the myofibroblast differentiation, and allows the apoptosis to occur. And we have to focus on the myofibroblast contraction, because when we do this, we can think about mechanoregulation of the tissues. So it seems a good choice to therapeutic interventions. We have to talk about the myofibroblasts because they are connected. They are totally in the field of mechanobiology, because they actively participate in the physiological and pathological tissue remodeling. They are mechanically active and contribute to changes in the tissue mechanics. They are mechanosensitive and mechanoresponsive, and its action and interaction with the extracellular matrix allows us to study the mechanobiological pathways and principles. So, since myofibroblast was discovered in 1971 and described in 1974 as a contractile cell responsible for producing extracellular matrix and also the wound closure, much research have been done to understand its correlation with fibrosis formation and excessive scarring. A lot, really a lot have been made in the past 50 years, all over the world, in France, in Canada, in Australia, in the United States, with Professor Alexis and Boris Hines and Ian Darby and Geoffrey Gertner, and also here in Brazil, where important findings were made identifying the effect of compression forces to induce apoptosis, which is essential to tissue remodeling. Well, what can we do with all of this? Based on experimental models, we have to think that mechanotherapies could be a good choice to balance the tissue. So the therapeutic aim is to minimize the mechanical forces, and then we can improve wound healing with better quality, and also reduce the scar formation. Well, based on this, we have to focus on physical properties of the extracellular matrix. We started our model thinking in, of course, this experimental model based on this work done by Ellen Langevin Group from United States, but they made it an active mobilization. And we wanted to know if it was possible to achieve the same results that they have achieved by doing only with manual therapy. So we made it, and we saw that it was possible to achieve the same results by making only manual mobilization. And here we can see in the first picture the normal skin, the subcutaneous layer of the mice, and the second one, the control group when we performed a lesion at the subcutaneous tissue, and we can see the amount of collagen fibers that we can assume that is the fibrosis. And in the third picture, we can see a better arrangement of these fibers with the active mobilization. And in the last one, the manual mobilization with quite the same results of the active one. The important thing in it is that we can make this arrangement by manual mobilization, protecting the scars that many times the patients can't do active movements, because we know if we have imbalance of surrounding tissues, we can make a better a worse quality of the scar. So we also have other results not published yet, when we could find that we can induce the apoptosis, reduce the inflammatory cells, reduce the total number of cells, and also increase type 1 collagen and reduce type 3 collagen. Our first results are published since 2018. Well, with all of this, how can we apply that on our patients? Well, I'm going to show you now as I see this possibility, okay? In my opinion, one of the most important things in the scar treatment is to visualize the skin as a three-dimensional structure. This is the basis of manual mechanomodulatory therapy, clinical reasoning. That's what I'm going to show you today. So we have to see two lines of trauma. One line, letter A, is the line of incision, when the surgeon penetrates the tissue and goes through the skin until the area that he wants to treat. And the line B is the line of undermining, where with the detachment is made. So both of these lines must be considered the lesion edges. And we have to pay attention in both of it. So how can we avoid the excessive scarring? It's all about the balance. We have to control the forces. We have to balance intrinsic forces and extrinsic forces as well. Professor Ogawa already showed that strong extrinsic forces can promote abnormal scars. So if we want to get close to scarless wound healing, we must pay attention to the edges and also to the sutures. We have to remember that all scar tissues is produced to fill the gaps. So we cannot have spaces, gaps between the edges, not only the incision ones, but also in the undermining ones. Because if we have space, we'll have a lot of amount of scar formation. So to get a better quality of scar tissue, the first step is to perform appropriate suture, as Dr. Mohammed will show us later today. Well, what is the manual mechanomodulatory therapy? Is one possibility to use this knowledge for prevent and treat scars, fibrosis, and adhesions. With MMT, we can treat regardless of time because we are treating a clinical situation when we see the density, when we see the lack of motion of the tissue, and we can treat as in no matter what, in how long. I'm sorry, I'm a little bit nervous. We can treat in whenever time, okay? So here I'm going to show some results for you. Here we can see perfectly clear an knee arthroplasty. The surrounding tissues are dense. We have edema, and we can see that the tissue is very, very affected by the surgery. So here we can see the treatment and 45 days after surgery with 2 MMTs per week. In here, a late correction surgery of hair lip. The patient was already 2 years of post-surgery, and the results after 3 months with 4 MMT applications only, okay, just 4. And in here, it's very interesting because we can see all of this vision of the three-dimensional structure. So the surrounding tissues, we can see the density, we can see the exaggerated vascularization, and the adjacent tissue density, darkened coloring, applying a tissue metabolic stasis. And we have, if we have density around the scars, we have an increase in the intrinsic forces and then hypertrophic scars. And here at the side, we can see after 2 months of treatment with 4 applications of MMT plus the shield. The shield that we do is using kinesio tape, like a lot of works of Professor Gertler has shown. So we do the shielding scars. Also in here, we can see the darkened areas showing the tissue metabolic stasis. And we also can treat orthodontic surgery, any kinds of surgery. These results is one of the I like the most because the patient could not do the reconstruction due to the presence of fibrosis and adhesions. So we treated this tissue when we could achieve more mobility and allowing the surgeon to put the prosthesis on. I have a video here to show you. In the beginning of treatment, we can see the surrounding tissues are okay, but the center is very stuck. The prosthesis cannot go in there. So we treated it, and after a few sessions, we could see that the tissue can move and we can grab the skin, making possible to do the corrective surgery. And here we see a result of liposuction. It's very, very common surgery here in Brazil, the aesthetic surgeries, and we have a lot of patients with fibrosis and adhesions. And here is the result with 3 applications of MMT. And here, multiple fracture, ankle fracture results after 2 months of weekly applications of MMT and also the exercises and etc. Here we can see a facelift with tissue compartment and the increased density impairing the blood supply. So when we move the tissue, we allow the blood supply to get better, and then this patient happened this. We could permit the blood supply to get okay, and the close and the. And here we have a burn patient with he made self-extermination. He tried self-extermination, and he was without movement when came to our service. And after 2 months, we could um, restore the movement and functional of this patient. And here the last one, it was a seamstress after 2 years of multiple surgeries and corticoid injections. She had a limitation of wrist movement and skin and joints. And after only 2 applications of MMT and mulligans, we have uh, a movement of her wrist, and she could work again after the treatment. And I put here the thing that she told me after the treatment, and it it's very good for the therapist to hear this. So she said to me, I spent 2 years treating my burn with needles and surgeries without being able to work. Lots of pain, and you, with only your hands, recovered the movement of my hand and took away my pain. I have no word to thank you. So the purpose of this treatment, it's not only aesthetics, it's most of all functional. Thank you very much.
Thank you, Marianne. And I think we have some time for a couple of questions. One was already asked in the webinar during your talk, and actually that was also something that I wondered about. And Maya asks you to please describe the therapy in detail. What is it actually that does the trick for you? There are numerous physical therapists, but you have found a special trick, obviously. Could you explain that?
Yes, yes, I will try, because it's not only one thing, it's a lot of things that we have to do. The first of all is that we cannot make tension, we cannot stretch the tissue, we only do movements. So we have to respect uh, what tissue allows us to do. You cannot stretch, so it's a move. Okay, it's hard to say without doing. That's why in the course I always talk to the students, we have to do in practice. And the other important thing is that you cannot beside the scar, and the movement must go through the scar. You cannot touch in the scar. The treatment is made by on surrounding tissues. And I think that is the most important thing. You cannot stretch, you have to move, and you have to respect the edges.
Okay, so those are basic principles. There are a couple of more questions coming in, and one of them from Andrea is also related to this particular aspect. And that is related to timing. When and the first question she asks is, can MMT be used to prevent subcutaneous tissue formation? And when to start that? You already explained during your lecture that you can do this both on existing scars and on relatively young scars. What is your opinion on that? What would be the ideal timing, and can you actually prevent scar formation?
Yes, actually, the MMT, it's not only the manual mechanomodulation. MMT is also, uh, we can also induce the flux of the interstitial fluid. So we can do maneuvers to improve the tissue fluid that we do an inflammatory phase when we only have edema. But this manual mechanomodulatory that we called, we can do as the moment that we have the synthesis of collagen. When we feel the density of the collagen, we can start to move. We do a very slow movement and without stretching, so it's safe. We don't hurt the tissue, we don't provoke, don't stimulate, just move to rearrange the fibers. So we can do whatever the tissue asks for. When we have density, we can start.
One more question from Laura. Please describe what are the similarities and differences of this approach to Sharon Wheeler's SCAR work?
Let me remember to Sharon Wheeler's. Oh, yes, yes. I met her at Fascia Congress because I think the Sharon makes in the scar. I don't treat the scar, I treat the surrounding tissues. I think that we can move the surrounding to affect the between the edges. So I don't do in the scar. I go in surrounding tissues and I don't do at scar. I think it's the most important difference because the movement is quite the same, but another difference, yes, it's more slow. Sharon make movements and quite a massage. Uh, MMT, you don't go fast. You have to feel the tissue. It's not automatically. You have to feel where tissues moves and go where it belongs, where it permits you to go. So it's quite different.
Yeah. So your technique is that based, do I understand that correctly? Is it based on tension reduction in the scar?
Yes.
And then one question that came to my mind during your talk is, what would your opinion be on splinting? I know that for scar prevention, splinting is still a technique that we don't really understand. We don't really understand if we should apply it, and if so, how long we should apply it. And especially over joints can be problematic. Nevertheless, we need often in for example, skin grafting, we need some immobilization during some time. What is
Yes.
your opinion on this?
Yes, I think the goal is to go on surrounding tissues because when you don't move the lesion site, you get a more safety technique and you can improve the lesion area with the surrounding work because you will improve angiogenesis, you will improve lymphoangiogenesis, and the matrix will be more balanced. So if you don't have this fibrosis around the scar and around the lesion will be balanced. That's exactly what Heyogawa tells us about the intrinsic and extrinsic forces. If you don't have the extrinsic forces pulling the scar, you have better quality. That's why. That's why. What I think, Esther. I don't know if I'm right.
Yeah, there's a lot to be discovered still in that area. Let me
Yes.
let me quickly go to through the questions that were already posed before the webinar started. Um, are there ways of scar minimization in patients that are known for ugly scarring? So I guess that is a question if this technique can be preventive
Yes.
for scar formation.
Yes, it's preventive because we start treating during the collagen synthesis. So when we balance the extracellular matrix, we don't have lots of fibrogenesis. So we can allow the wound healing process to go, can I say, more normal without excess, without a lot of collagen.
Yes, I understand what you mean, without excessive collagen formation.
Yes, yes.
Yes. Okay. Very, very good. Thank you very much. There are, I think you should take a few minutes to go through the comments. Many compliments from the audience for your talk. Thank you very much. I also would like to thank the attendants posing questions in the chat, and I think we now will move on to the next speaker in this webinar, and that is my good friend Dr. Peter Moortgat. Peter is a physical therapist as well. He has also a Bachelor of Science in Physical Therapy from the University of Antwerp, specialized in burns physiotherapy since many years. He is also working at OSCARE, which is an aftercare and research center specialized for burn patients. And he himself is specialized in physical scar management and research. And he is also the academic coordinator of SCAR Academy since many years, guest lecturer, and also board member of the Global SCAR Society and of the European Tissue Repair Society. Peter's talk today will be the pinprick, the second part of the title of our webinar today. And he will show us some results and some ideas on microneedling as a technique for scar management. Peter, the floor is yours.
Thank you very much, Esther. First of all, I may be many things, but I'm certainly not a doctor. So let's stay with the physical therapist who has a lot of interest in scarring and other things. Okay, let's share our screen. Good. First of all, before I start, I want to thank the company Dermaroller who made this webinar possible. And they are the sponsors of this webinar. And I will be talking about microneedling, and I will be talking about all the treatments that we perform also with the devices of Dermaroller. This is the agenda of my presentation. First of all, I'm going to give a short introduction on microneedling. Then I will be talking about medical needling. We're going to introduce a new device, an electronic needling device from Dermaroller, the Twist. And then we come to the practical part. We show you a lot of before and after pictures. We're going to talk about a few studies. And finally, I will show you some videos that will give you an idea of the work that we do at our center. So first, the introduction to microneedling. So what is needling? Needling is also known as collagen induction therapy. So there are a lot of names for one treatment, like percutaneous collagen induction, microneedling, medical needling, dermal needling, all meaning the same. The difference between other more cosmetic needling procedures and medical needling is that with medical needling we use the longer needles above 1.5 millimeter, and we try to reach the dermis where we can make some changes in the extracellular matrix. You are pricking the skin multiple times, so we are here in the pricking part of this webinar, and that multiple times is of course due to the fact that you go over a scar with a roller or with an electronic device, and you make very tiny micro channels of only 50 to 100 micrometer of diameter. And our goal is to induce new collagen formation. We try to remove and the scar collagen and replace it by healthy collagen tissue. And one of the points how we can reach this is the fact that these tiny pinpricks, the wounds close within 2 to 3 hours after the treatment. So you have a very fast wound closure with normal collagen formation afterwards. So you give a sort of reset or reboot for the cellular function inside, and we try to reach homeostasis there. The effects of microneedling can be found on a dermal level in the collagen fibers, on an epidermal level where we have some reactions in the keratinocytes, and at the epidermal-dermal junction where we can reach the melanocytes. And these three parts, we're going to take a closer look at them. For the collagen part in the dermal level, we see that after 3 to 5 days after the needling, the proliferation phase starts. We see the formation of granulation tissue, and we see the fibroblasts proliferate into the wound with the help of fibronectin and TGF-beta. The collagen type 3 formation becomes maximal after 5 to 10 days after the needling. So we try to replace the scar collagen by a healthy collagen. For the keratinocytes part, we see that keratinocytes, when they function optimally, then the epidermis becomes thicker. So that's also one of the effects of microneedling, is that we always see a thicker epidermis with a better epidermal function also. That means that the function of the epidermis is working better afterwards, and that also with chronic wounds, you can make your epidermis thicker and we can reach a better homeostasis inside. So we get skin barrier restoration. The keratinocytes, they release keratinocyte-derived anti-fibrogenic factor and also keratinocyte-derived community-stimulating factors. So these growth factors, they regulate degradation and synthesis of the MMP1, the collagen 1 and the collagen type 3 fibers. So this all suppresses the inflammatory process. It's very important that with the needling, you only reach a superficial inflammation afterwards. Because if you needle too dense, then the inflammation process will not be superficial anymore, and then we will not reach the same effect as we have a superficial inflammation. At the level of the melanocytes, we see that they work in synergy with the keratinocytes, and a decreased keratinocyte function always leads to a higher inflammation with pigmentation disorders as a result. So we can get hyperpigmentation after more inflammation. So the damage to the spinosum layer, that leads to the hyperpigmentation, and the needling restores the keratinocyte function, as we saw in the former slide, and it normalizes also the cell crosstalk with the melanocytes. It also regulates the MAPK activity, preventing the overproduction of pigments. So let's take a look at medical microneedling. So for the rollers, there are a lot of devices, and originally it all started with the medical rollers. We see that there are different lengths of needles, and we talk about medical needling when the needles are between 1.5 and 2.5 millimeter long. This is performed by a medical practitioner, and you can reach all the skin layers up to the hypodermis, depending on the thickness of your scar. The needle length is maximally 2.5 to 3 millimeters. So that means that you will not get any deeper initially when the scar is thicker than 3 millimeters. The products, most of all, we use the 2.5 millimeter needle length with scars. And when the dermis is thinner than 2 millimeters, then we use 1.5 or 2 millimeter thickness. Length of needles. What is also important is product conformity. On the market, we see a lot of rollers being sold by Chinese companies most of the time. These rollers, they have CE markings, but CE markings without the 0482 number, which means that the CE marking, everybody can put a CE marking on its product, but it's important that you use rollers which are CE marked with an assessment of quality management here. If you don't use these types of rollers, if you use the very cheap types of rollers, you have the risk of needles that are coming loose, needles that can bend, or you have the risk that they are not properly sterilized. We use different grip options for different goals. Let's say if we only are treating smaller scars which are not too thick, then we can use a grip which allows us to work more let's say, more specified and more precise if we have to put more pressure on the rollers and try to work with larger and thicker scars, then we use a grip like on the right side where we put the thumb on top of the rollers. The rollers are made ergonomically shaped so that you can use all these sorts of grips any way you want them. And then it's time to introduce one of the new devices of Dermaroller, which is called the XLRS Pro Twist. It's in pre-market launch now, so it will be on the market very soon. It's an electronic needling device. So, and why should you use this device? Well, when we take a look at the market, there are a lot of electronic needling devices that we can use and that we can buy. Some of them are very good. A lot of them are no good, let's say. And most of that depends on the type of engine, because you have to have a very powerful engine, because if you use a weaker engine, then your needles will go in and out with less power, making bending of the needles or tearing of the skin more possible there. So the Twist is a Class 2A medical device and is equipped with a very powerful handpiece. You can set the needle length from 0 to 2.5 millimeter. It's also operable with a foot switch, so that you can stop with the foot switch and start with the foot switch again without having to use your hands. It allows accurate and invasive treatment, and the intensity can be set up to 150 strokes per second. The frequency can be as high as 150 strokes per second, which enables a fast movement with no scratching or no tearing of the skin. Most of the time in our practice, we use 100 to 120 hertz, so 100 to 120 strokes per second. If we take a look at the needles, the needle modules, they consist out of 6 precisely ground needles made of surgical steel. These needles often differ from needles from very cheap devices, where it has been found in the past, if you use the very cheap devices, that you see needles like here on the pictures on the right. Needles that are not shaped very well, and these needles, when they are put in and out of the skin, then they can damage the skin and tear the skin, of course. Skin by vibration is counteracted by the needle protrusion, and you can set your needle length with steps from 0.25 millimeters from 0 to 2.5 millimeter. And then one of the unique patented selling points of this device is the active needle retrieval. So the combination of a very high powerful engine with a special needle module connection and an angular drive, they enable an active needle retrieval, which means that you don't have to put any force to get the needles in and out. So when you want to work quickly to reduce your treatment time, the risk for ripping and tearing of the skin is avoided here. So that patent coupling point is unique in the needling world. For indications, you could use this at, let's say, harder to reach areas, but you can also use it for the cosmetic aesthetic treatments of skin tightening after a medical or surgical follow-up, and also for the treatment of surgical and burn scars afterwards. And it's very suitable for the perforation of the skin surface and together with the introduction of active substances. So these are most of the indications. We use it also to treat pigmentation disorders, where the rollers are not so suitable as this device, and other indications. If we take a look at the needle modules here, They are made specially for the twist. They are individually and sterilely packaged, and it's a sort of flowback safety system, which allows them to not stay in the skin after a retrieval manually, let's say. There is no cross-contamination due to the shape of this needle module also. It's also CE marked with the 0482 number. Let's take a look at the disadvantages when you use pens, cheap needling pens, which also can be found on the internet at very low prices. There you see that our needling pens, they have no control unit, no foot switch. They have low power engines most of the time, short lifetime, no flowback safety systems, and a higher risk of cross-contamination. Most of the time you only see a CE marking without a number being put on the packaging. So there is no product liability insurance here. When we use this device, we also use a sort of hyaluronic acid gel lubricant to put on the skin before we use the electronic device, the twist, which allows the device to glide over the surface more easily. So it minimizes the risk for allergenic reactions, and it also makes the treatment a lot less painful. And that's why I like the device quite a lot, although I'm only using it since a short time, but a lot of my patients say that it's a lot less painful than, of course, the rollers, but also the use of a tattoo gun or some other electronic devices. So if we compare the rollers with this electronic device, then we can say that the twist, it creates more microchannels, around 900 per second, which means that you can make 1 million penetrations in 20 minutes. It's also usable for hard medical scar issues, also for face treatments, and it enables you to set your needle length up to different lengths, so you can treat different depths of injury at the same time without having to change from device, let's say. It's less painful for the patient than the rollers. With the rollers, you often need to add a sedation with a local anesthesia. And here only, let's say, a topical anesthesia is enough before the treatment. Of course, it is a higher initial investment for the practitioner. Then the traditional rollers, they enable faster treatments of larger areas, and it's also used to treat thicker scar tissue, because you can adjust your pressure that you put on the roller to treat your thick scar tissue. It's also a lower device investment when you compare it to an electronic device. So let's take a look at some before and after pictures here. Here we see a treatment with a roller. It's a scar on the ankle. The scar at the time of the beginning of the treatment, it was already 14 months old. So the scar still remained very thick and also very red. At the photos next to it, the first photo was taken after 1 treatment, the second one after 3 treatments, and the last one after 5 treatments. Time in between treatments was 6 weeks to 8 weeks always. So you see that the redness of the scar improved a lot. It was almost completely gone after 5 treatments. And also the height of the scar decreased a lot, which you can see in these pictures. We always use an ultrasound scan to measure our scar thickness before and also after the treatments. We take that ultrasound scan before every treatment, so it's been giving us the result of the former treatments.
So for the same scar as we saw in the pictures before, we see here the ultrasound graphics. So this was the one at baseline, which was a very thick scar with almost no pixels that can be seen, which means that the scar tissue was very close to each other. After one treatment, we already see a change in the papillary dermis, where we see more pixels, which means more space between your scar collagen. After 3 treatments, the scar became a lot thinner. It was reduced by 50% already, and you see a lot more pixels there. And this was our result after 5 treatments, where the pixel density was almost the same as healthy skin, and that result can be seen as quite spectacular. Here we see 2 scars at the left at baseline, just a few months after surgery, and then after 6 months, the last pictures of that, and you can see quite nice results for these scars. Please take in mind that at our center, we always do combination treatments. That means that needling is not the only treatment. Most of the patients also follow manual treatments in between the needling sessions. Some of them do not. That are patients that most of the time they live too far away from the center. But it's always preferred that you use combination therapies. For acne scars, it's also very suitable, but we use 1.5 millimeter needles here. So this patient was treated two times with a 1.5 millimeter roller, and you see the results after 3 months there. At home, the patient also treated her scars with a home roller of 0.2 millimeter needle lengths. This is the same scar on the forehead there, also 2 treatments. And here we see a result of microneedling on pigmentation disorders. So it was a 3-year-old post-burn, hypertrophic, but especially hyperpigmented scar. And after 1 treatment, 8 months later, you can see the result already, and the hyperpigmentation improved a lot. And since the scar was already 3 years old at the beginning, we can assume that there was already maturation in place. So the effect was fairly due to the microneedling alone. This is one of our patients where you can see a scar that was 1.5 years old. So it was still quite active, quite red and very thick. And at the right, you see the result after 1 needling treatments, 3 months after the treatments. It has been done with a 2.5 millimeter needle length. Another example of a scar, also I think 1 year old, still very red and a lot of texture visible at baseline. And after 3 treatments, 6 months later, you see the result, and we have a significant improvement in color and texture there. We also saw the result of hyperpigmentation and the improvement of that with needling in this traumatic scar. It was a traumatic scar on the leg, and at baseline there were still a lot of hyperpigmented zones, which improved a lot after 1 treatment, and this picture was taken 2 months after the treatment. Here you see the effect of microneedling on stretch marks. This was done with an electronic device, and you can see the disappearance of the stretch marks and also an improvement of the pigmentation there. So then let's talk about some studies. There have been performed a lot of studies. I'm not going to show all of them to you. First of all, maybe one of the most important ones in the beginning
was the dermal roller study itself, which has proven that indeed microneedling can be considered as a collagen induction therapy, where we saw a lot of new collagen formation in the papillary dermis. It was the study of Horst Liebel, which was performed in 2012. Then another interesting one was the study of the University of Marburg, where it was proven that normally when you try to induce and absorb active substances into the skin, then we see that even with small liposomes, they penetrate the skin with only 0.2% of the substance in a period of 12 hours. If you pre-treat the skin, however, with microneedling, then you can increase that substance absorption and penetration by more than 1000% already. And this was also an interesting study in 2009, which showed the magnitude of our pore size, let's say. With the pricks, it means that we proved that Dermarol proved here that the pinpricks only have a diameter of 30 to 100 micrometers. So they are very small channels. In the skin, they only go up to 50 micrometers. So that was also very interesting to know. Even if your needles are thin, it's not always sure that your pore size is as small as the needles. Then let's go back to a study that we performed in our center, where we tried to investigate the effect of microneedling, dermal needling, on the thickness and density of burn scars. And then we see that with the POSAS from the patient reported an improvement of 44% in thickness, also more than 40% in stiffness. So it became more pliable, texture, and global opinion too. And if you see on the right, the blue line is almost completely within the green lines, which means that all aspects of the POSAS patient improved after 6 months. The same for the observer. There we see some lower results. Most of the time that's due to the fact that the observers are experienced clinical people who see a lot of scars. So that means that a patient almost always rates his scar higher than the observer here. And if we take a look at the numbers, then we see that the scar thickness improved by more than 1.5 millimeter after 6 months. So we see a significant improvement with also a very high effect size. Dermal density, which means the number of pixels that we see, so the space between the collagen fibers, also improved a lot. And here the effect size was even higher. So now to finish my presentation, I want to show you a few videos with the new device, with the twist. So first here we see a patient with large scarring from burns on his trunk as well as on his face. The first part of the treatment was done with a roller. So we see that I already treated the trunk and the neck with the roller, and now I'm going to treat the face part with the twist. Here you see that we use the lubricant before. And then we start the treatment here, and you will see that you can easily go over the skin without harming or tearing the skin. It's the patient before in his face, he was also treated with a roller or with a tattoo gun. And what he says here now, it's in Dutch, it feels more like a razor machine, and it's more like swiping over the skin instead of pricking the skin, really. So for him, it was a lot less painful than before. Here you see the same patient. He also had some very stiff scar parts above his nose there, between the eyes. And also here you can see that it works very smoothly. In the neck part, I treated first with a roller, but there are some places there that have much stiffer lines than the rest of the neck. So these places were also treated afterwards with the twist, because there we could work more precisely on those smaller, stiffer parts. You see that we always stretch the skin before starting to use the device. That's also necessary to avoid damaging of the skin. This was also a very good indication for using the twist here, because these places cannot be easily reached and easily treated with a roller device, because there with the roller you have different intensity of rolling, because there's not too much fatty tissue under the skin, and therefore at some parts you will roll harder and at other parts it will be softer. So to allow an even distribution of the pressure, the electronic device is more suitable here. And this last one is an interesting one. Just did it this morning. It was the second time that I did this procedure. It was done with a roller, but this patient has hypopigmented scars. So what we are doing here, we treated the scar with the roller first, and afterwards we applied eye drops called bimatoprost. And one of the adverse effects of bimatoprost is that it creates hyperpigmentation. So that means that you could use them to improve your hypopigmentation. I saw this being used with microneedling and with laser by other specialists in the world, like Jill Wabel, who is a very good laser specialist. So we also started to use this, and we're very curious for the result, and hopefully in one of my next encounters with you, I can show you the results of these hypopigmented scar also. And to conclude my presentation, I would like to quote my good friend Matthias Aust, who is probably one of the most famous specialists in scar needling. So needling allows repair of the dermis and no ablation. It stimulates collagen synthesis without creating fibrosis. It stimulates scarless healing, although I must say we don't pretend to talk about scarless healing, but we talk about less scarring. So we already filled in the last 4 letters of the word, so maybe we can speak about scarless healing instead of scarless healing. And we also perform a stimulation of growth factors. So thank you for your attention, and any questions are welcome now.
Thank you very much, Peter. A burning question from my side. And that question came to me when I looked at your videos. How do you know how long to proceed on one place? I saw in the video that you moved along the scar for several times. How do you know how many times that you have to go on one particular spot?
That depends a little bit. With the roller, it's always, let's say, the puree, which gives us an indication of when to stop. When the scar, when the tissue that you treat is becoming purple, it means that your angiogenesis has been started already, and that you know that the wound healing cascade has started. With the electronic needling devices, you will not get the purpure on an even manner, but the parts of the scar which are still the most active, they will show you already a more darker color than the other parts. When they become quite dark, then you can also stop, because you also know that on these parts, which are the parts that you want to improve, that you have reached your wound healing cascade starting point already.
Okay. Questions from the audience. There are several questions. I hope we will be able to cover all of them. Let's start with a question from Vivian, an early question from Vivian. Is this technique suitable for wounds as well? You talked about chronic wounds at the beginning.
Yes, indeed. We tried it on a few chronic wounds already, which were wounds, let's say, hard to heal wounds in the beginning of the treatment, of the aftercare treatments of burns patients. They still had wounds that kept going open. So we treated them with the microneedling, and we saw the epidermis becoming thicker, and the wounds were eventually completely closed afterwards. So it can help you to treat wounds, even maybe fresh burn scars. But I leave that to my colleague Matthias Haust to determine whether that is already a fact or not, because he is testing it on also on fresh burn wounds.
That relates to a question from Carlo. When to start in hypertrophic scars?
Well, it depends on what is your aim, what is the goal of your treatment there. If you have a lot of other treatment options also. Microneedling can be done at any point. It's a regenerative therapy, which means that it can be done early in the early stages, but it can also be done on very old scars. You reactivate your scar there, and you can reset or reboot your cellular functions inside. Most of the time, when we have larger burn wounds, let's say, and which are crossing also joints, then you have to be careful, because you are changing the mechanical forces which work on the scar tissue, and you cannot predict. It's like a spider web. When you cut a few of the fibers, then they will be replaced by other fibers, and your mechanical forces, they change. So I would not suggest to use it in early stages on larger burn scarring, let's say. But for every other scar, you can use it as well in early stages as you can use it in very late mature scars.
And are you aware of any evidence that actually the metalloproteases are elevated after the dermal roller or pinprick treatment, after the needling?
Yeah, there was a study performed by a German scientist, Schmidt. He looked at the genes, elevated and down-regulated gene profiling, let's say, and there he could see that all the pro-fibrotic genes were down-regulated, while the anti-fibrotic genes, which Paul also pointed at the MMPs, they were up-regulated.
Okay, another question from Carlo related to the subject before that we discussed. How does this technique compare to laser treatment?
Well, I often refer to it as the poor man's laser. It definitely does the same things, except that laser also induces heat. So, which means that laser can also modulate heat shock proteins inside the body. This is not possible with microneedling, although we see with the gene profiling that maybe one or two of the heat shock proteins are also changed from gene profile. But yeah, laser treatment is often a lot more expensive than a microneedling treatment. On the other hand, some of the lasers go deeper. If you use a CO2 laser, a fractional, they can go up to 4 millimeters, while with your needling, you can only go up to 2.5 or 3 millimeters there.
Okay, and then to close up the discussion after this lecture today, Jocelyn asked if this technique is also suitable for diabetics who have a history of difficult wound healing.
Yes, perfectly normal for that. The pinpricks you make are so small, and the wounds they close so fast that even with people who have a history of hard to heal wounds, we still see quite a fast wound closure there. Maybe not after 2 hours like with other patients, but still they see a wound closure after 4 to 6 hours.
Okay, thank you very much, Peter. I think in view of the time, we need to stop the questions and answers here. There are a couple of remarks in the chat that we haven't been able to cover, but perhaps Peter can have a look at that. For now, thank you very much. And again, thank you also to the audience for posing the questions. And now we will go to the third lecture of this afternoon, the last lecture on surgical management of the scar from the start, novel techniques, and that will be introduced by Dr. Mohammed Al-Azrak, and I'm very pleased that he can join us today. Dr. Al-Azrak is a plastic surgeon consultant. He graduated from Cairo University, has finished his general surgery training as well as plastic surgery residences in Cairo and Fayoum in Egypt. He obtained a master's degree in surgery and burn treatment and also a PhD in plastic and facial surgery from Cairo University. And he is specialized in wound healing, burn treatment, scars, as well as facial surgery. The floor is yours, Dr. Al-Azrak.
Thank you, Professor Esther, and I would like to give my congratulations to you for this webinar, as well as for the other speakers, Marianne and Peter. Thank you. Yes. First of all, surgical management of the scar from the start, novel techniques. I'd like to thank the team of Nippon Medical School, led by Professor Ryugawa. I have a good connection with them, and I spent useful time with them. And the first thing I would like to introduce the content of this lecture, which is Introduction and Basic Wound Healing, Non-Surgical Management of the Scar, Surgical Management by Skin Grafts and Flaps, Algorithm of Approach, Scar Revision, and Surgical Prevention, Management of the Wound and Scars, whether superficial techniques and deep techniques. First of all, the basic wound healing must be understood by every practicing physicians and surgeons in the modern plastic surgery. And George Jensen produced descriptive differentiation, which is hemostasis, coagulation, inflammation, angiogenesis, fibroplasia, contracture, and epithelializations, and skin remodeling. I think I will go rapidly to this, but we would like to remember the role of fibroblast, keratinocytes, myofibroblasts. The fibroblasts has a major role in wound healing and scarring, especially also the myofibroblasts. Also, we should remember the extracellular matrix components. The bullet information I would like to introduce before going to surgery is decreased inflammation and immune response lead to less scarring. Wound contraction is a balance between repair and restoration, studied extensively by Ionis Yanis, which is major researcher in this field. Increase in mechanical stress and tensions lead to increased scarring and keloids. There's a nice paper produced by Professor Toriko Duri, also Professor Ryugawa and Jeffrey Gardner share in this paper, which is useful in distribution of tension along the body and increase scarring with increased tensions. Tensile strength is a very vital item we should know and consider during wound healing. The collagen deposition and remodeling contribute to the increased tensile strength of the wound. So it reached about 20% at the original at 3 weeks and up to 70 to 80 of the original at peak of 60 days. We should remember this information. It's very vital, and we built up technique up on this information. Remember also, basement membrane zone, which is the junction between the epidermis and dermis, is very vital and changes with age and allows sliding between epidermis and dermis and also affect the refining of the results. Reticular cutis fibers, which connect the cutaneous superficial layer up and down, and it connects to the deeper structure up to the periosteum. So it's a connection between superficial and deeper layer. Management of the scar, non-surgical methods, actually is not my topic today, but I suggest a paper which I have read it before a long time in 2009, Prevention and Curative Management of Hypertrophic Scar Formation. And by the way, Professor Isir Middelkrop is sharing in this paper. Surgical management of the scar is our topic today. Let us start. Contribution by Professor Ryugawa and Juri Arima is a good contribution recently in 2019. They describe the distribution of tension superficially by Z-plasty as well as repairing of the deeper techniques. Deeper muscle contraction is decreased by injection of botulinum toxins, which was a contribution by Dr. Adil Wilson here in Cairo. In 2006, he started this technique, and in 2013, he published it in Canadian Journal of Plastic Surgery. He tried to control the contraction of the muscle and allow to tensionless healing. Tissue adhesive tapes, and adhesive device all help in refinement of the results. Tissue adhesive have possibilities that have no superficial scar, but actually it can't carry tension. Adhesive tapes is useful and you can apply it, but it's not alone. Also, adhesive devices, recent adhesive devices, is also efficient like Zeppelin or like this. Surgical methods. Surgical methods means surgical revision, scar revision, and surgical prevention, which I pose this term. We can prevent surgery from the start. Also skin grafts and skin substitutes, also flap and tissue expansion and prefabrication of flaps. I will discuss the skin graft first and the flaps and let down surgical prevention and surgical scar to the later on. We can put a skin graft, whole thickness skin graft early to prevent scarring and treat scarring as well. And I fixed it by human hair in like this case, and we have a nice healing results. You can use also flap in early burn cases which are not healed. You can use a flap. This is a perforated facial artery flap from the facial artery below the mandible. I can design a useful flap, pliable flap, and show here the perforators, and you can rotate it 90 degrees to cover the defect and produce covering and less scarring. So let us manipulate the scar well surgically. This is a scar with a defect. We can use this scar as a flap and produce lining of the defect inside the nose and rearrange the tissue locally to have a nice reconstructions with less scarring. Also, this is a case of atrophic hypopigmented or soft tissue loss. We can analyze the defect. We would like to have a tissue which resemble the skin color as well as fill such a defect. We can design a flap from submental artery perforator. We have here 3 perforators. We can select the most suitable according to the perfusion and the arc of rotation. Then we can elevate the flap and twist it to reconstruct such defect and have a nice color match and filling of the defect with nice contour. Tissue expansion is a well-known technique and very useful in scar reconstructions, and we can thin the flap in order to match the harmony of the thinnest skin of the face. This is a keloid. We can reconstruct it by a perforator flap from the intercostal, and you can prepare the flap and rotate it to cover the defect with tension free. This is also a contracture, the axilla with the scarring, and you can excite the scarring and release of the contractures and produce a flap from the circumflex scapular perforator systems, and you can propel it as a propeller flap to reconstruct the defect and the release of the scarring. We can also apply this at the knee joint from the superior genicular artery. You can perform a perforator-based flap, and you can release and excise most of the scars and release the contracture and reconstruct it by such useful flap. So let us start our topic, scar revision and scar surgical prevention. First of all, you should consider this algorithm while you are management, wound or scar. So scar revision also produce a wound which is surgical wound. So we speak about what? Surgery not alone. It should be preceded by pre-surgery preparation and post-surgery also, follow-up and management. So before doing any surgery, you should consider pre-surgery preparation in the form of proper assessment and the discussion, considering the psychological element of the patient and understanding of her case or his case, and availability of available techniques, and he can accept all the available techniques well. So you must discuss with the patient about the progress of his case along the management plane, which is total management plane. The wound or the scar should be examined, and the examination of the scar have a various tools. You should consider examining it statically and also dynamically with movement of the joint or contraction of the surrounding muscle, and examine the defect which is present in the scar. Also examine the wound well. Surgery should be considered of two techniques, superficial techniques and deep techniques. Superficial technique, we have suggested superficial epidermal sutures by hair filament. We will give a hint about this. And this is the topic today, deep separation refixation technique, management of the deep tissue by this technique. Post-surgery is important as surgery, which involve early stage and later stage. Early stage, you should apply topicals, moist, antibiotics, some blocks, or early application of silicone if needed, or stem strips. And later also, you can say the scar or the healed area in need of topical silicone, injection of corticosteroid, compression, laser, re-revision, or other modalities. So a scar have two major problems, the cross mark and the widening, mainly. So widening is a problem and cross mark is a problem. Cross mark, we have produced a technique of dermatologic microsuture previously to decrease the cross mark. We have used human hair and have a special characteristic. The paper was published in 2017, Al-Azrak and Ogawa, and we have observed many beneficial effects from using of hair. In all cases, the hair was pliable and smooth and provide effective tension, and it was harmonized with the skin tissue. The node was secure, didn't exhibit dehiscence, and the stitch accommodate the local wound edema and didn't cut through the edematous tissue. The stitch was easily to remove, and the patient appeared to feel less pain on suture removal than our experience with other suture material. Also, the cost and availability issue are not encountered. It was a useful technique, and we have applied it simple interrupted sutures as well as continuous sutures with good results. You should consider local wound care. Time paradigm is important. Items should be considered: the tissue and the infection and moisture and the edge. You should apply suitable local antibiotics. You should apply moisturizer if needed, and you should keep the edges and protect the edges for a long time in order to refine the results. You should take the best results which enable us to avoid any additional needed intervention. So let us go deeply. The ordinary management of the wound for a long time was when you face a wound, you try to fix layer by layer. So you fix the fascia if injured, the subcutaneous fiber fatty, and do meticulous closure of the skin. But actually, when the wound occurs, there is a relaxed fibers, connecting fibers, and stretched fibers. The dynamics changed. So you should look by different way. The ordinary way that you grasp every layer with each other in order to produce this type of common repair pattern. And this actually doesn't have the ability to bear a huge tension. As we said before, it is the weakest point in this area is the skin normal, and this is the weakest point. So at the maximum chance, the healing doesn't exceed 80%. It doesn't reach 100%. So it leave a scar, should leave a scar, because the tension is concentrated here. Our technique is deep separation refixation pattern. We started to think differently. We started to think differently by consideration of the scarring from the start. So you manage the wound considering that it will leave a scar. So what we will do, you will go deeply and separate the cutaneous layer from the deeper structure, cutting all of these fibers up to 3 to 5 centimeters around the wound, as well as you dissect the superficial fibrofatty layers and separate it from the deep fascia. Also, you dissect and separate the deep fascia from the superficial fascia and from the muscle if needed, if present. And try again to repair layer by layer, considering tension control. So you should do here in the deep fascia, double breasting is a suggested type of repair. All trembling with tight closure of this area, or this area also. Trembling, shortening this area, this layer, which is lamellated before, and tight closure can grasp this layer tightly in the center. You can do plication of the muscle if it's needed. And finally, the direction of the fibers stretch is changed. So tension comes here to this, which is T point. T point transmit tension from superficial area deep, avoiding such area, and deep to this area. So fibrosis and healing is in such area is more weight bearing. And this area, which is cutaneous area, sutures finally have no tension or less tension as possible, especially in the early stage of healing. Tension is transmitted deeply, so superficial scar is less until subcision of all tension distribution of this. Let us apply the ordinary type to traction forces, traction pull-on, and expansion. When we do tractions, the traction forces distributed all over the layer, especially on the superficial layer, causes scarring. Also, the expansion forces or pressure reach the surface area more rapidly. Our suggested pattern is that traction forces on the cutaneous layer escape from here to deep layers. So this flap is lax for a long time, allow nice tension-less healing. Expansion forces as well, when applied, it is resisted here, not reaching the surface at least for 2 months, which is early phases of healing with tension free or tensionless. So scar is more or less nicer. This is the first case I have done in 2030. I'd like to present by it, because when we face a wound, you try to close directly this wound. Actually, you must think differently. You should open the wound. Lamellation of the layers have been occurred using also smash, and these layers can be trimmed and tightly closed. So the tension is here, deeper. Tension is deeper, and the flabby skin flap can be sutured easily and approximated easily. But you used its own hair to meticulously approximate the edge and close the wound. I have seen this case after 1 year, and nice, very nice scar actually. But I would like to refine the results using adjuvant modalities. So this also another case. We have do deep separation, and we separate this fibrofatty layer and do double breasting using BDS number 0. And this repair have been was very strong repair, and you can see the flabby skin tension-free can cross to the other side, so you can meticulously close this. And this line carry the tension, not this line. So we have changed the line, the tension line, to this line outside of the healing area. You can see after 6 months, after 1 month, after 3 months, it's very nice healing. Actually, the superficial, the wound in the upper part was treated normally. So the scar is more, this scar is better than this scar, usually. We can see this wound, and we go deeply and separate this layer and repair it tightly with double pressing. And finally, you can see the healing is very nice compared to the lower wound, which is treated normally, which have a more worse scar. This scar is more finer than this scar. This is also another angles. We can dissect the layers and do a deep refixation technique, which control the tension deeply and separate it from the superficial, repaired layer. So with gradual time, you see that release of tension flatten this area, and the skin regain its normal position with very fine healing line. You can see this. You open the wound and do lamellation, separation of the layers. You can do hair plication if tension is exposed to be transmitted from the masseter muscle. So also you do double breasting, and this is the repair zone, which is very strong zone, and the flabby skin, tension-free skin can be handled. When we follow these cases, this is the first week, and during the 2 months, week 60 days, there is a gradual loss of projections and flattening gradually until 8 weeks. And the remaining part, the remaining area, we have a nice fine healing line around 1 milli or less in width, which is very important to have a very narrow line, which is aesthetically preferred and aesthetically high in aesthetical perceptions. So we search an aesthetical scar which is not visible by the ordinary activity of this patient, so avoiding any psychological implication on the patient's life. So we can do scar revision. Starting scar revision is an issue that should be preceded by huge discussion with the patients, taking the history of other treatment modalities have been applied, and finally discuss what can be achieved and what is the problem with this patient after this examination of the scar. Scar usually hyperpigmented, and there is a defect that should be considered and treated. So you can depithelialize and use this fibrous flap and separation of the deep fibrofatty layer. This fibrous flap can be fixated deeply here and crossed by this fibrofatty layer to be fixed here, and this flabby skin flap. This flabby skin flap is closed, and you can follow up the case to find nice healing during the healing process, and the fine line is noticed hardly. So you can go courageously to such scars, which surgery needed to be meticulously done, and actually there is other modalities tried to treat this case, but we can go by surgery to this case courageously in order to gain satisfactory results, and actually we succeeded. This case can be managed by separation of the layers, deep layers, as well as use of this tissue to reinforce the repair, and finally you find that closure of the superficial defect without any superficial suture alone. Just repair, deep repair can produce this. You can close by human hair, and finally it's very nice result. This is a surgical rule in such challenging scars. This is also most challenging scar. We have tried surgery with success. There is also another scar in huge tension areas, and actually I propose
I think we have a small technical problem here. I think Dr. Al-Azrak is reconnecting to the
of the superficial area by human hair. And finally, you find a nice results, which is accepted by the patients. This is also a huge scar with fibrosis and adhesion of the layer, deep layers. Actually, other surgical modalities can help, but we should dissect and release all of the adhesion to the deeper layer and release and free the skin flaps, as well as starting to bilacation of the deeper layers and start the repair from deep to superficial. This swelling will carry the flabby skin, as well as will absorb the tension along the daily life and daily movement of this patient, and will resolve with time until we can find the final results after at least 6 months. This is a challenging cases, and we can apply it at the knee joints. This hypertrophic hypopigmented scar is challenging. We can apply other non-surgical modalities, but I am not sure about the results. But actually, we start surgery in these cases. I separate these layers from the deep surrounding areas, using also the surrounding the fibrosis in this area, excise it, and separation of deep lamellation of fibrofatty flap. This is the flap separation from the upper and lower part. And also we can do plication around the knee joints, and then close by double breasting in order to produce a very strong repair, which can carry the burden and disperse the tension from the superficial layer. This superficial skin is flabby, and meticulous repair of the epidermis can be done, which we can find a very nice accepted result at the end. Finally, I would like to produce some take-home messages. First of all, is prevention of scarring is of utmost importance. Start early in order to have a good position in the train of healing. Early and adequate epidermal restoration is vital in controlling of scarring. Dynamic as well as silent tension control should be considered. Balance between repair and regeneration. No minor surgery with regard to facial surgery or scarring. No single modality can be sufficient in management for less scarring. Epidermis is the mirror reflecting the internal as well as external environment. Try to exert more effort if needed. Basic wound care with various methods lie adherent to the time paradigm. Scar evaluation and assessment. Use multiple approaches to evaluate the scar. See the patient as a whole and make the best that you can, even in ugly man. Thank you very much.
Well, thank you very much, Dr. Al-Azrak. This is, I learned something this afternoon, and because we had a question in the pre-announcement of the webinar already, which had the abbreviation DSRT, and I didn't know what that meant, but now I know, because this is the what you just explained, the deep separation refixation technique. And the question that was asked was, is this suitable for cesarean section as well?
Yes, okay. First of all, cesarean section incision is a common incision daily. Sometimes with repeated cesarean sections leave a fibrosis and adhesion in between the deeper layer and weakness. Revision of scar as a whole, you should consider all the layers, deep layers and adhesion. A deep separation and fixation technique can be applied anywhere in the body, and you should put in your mind that first of all, cesarean section incision usually is tension-free from the start, but the problem usually is adhesion. So you can dissect the layers and repair it by sufficient method of repair, and then you can do the superficial layer meticulously, and we'll have a nice results. Also, no problems to do Z-plasty if you say that this will help the patient. And abdominal scar surgery usually benefit from Z-plasty as well as repair of the deeper facial layers. Okay.
Thank you. And another question I had during your talk was, I was also intrigued by your use of the hair as a suture.
Yes.
And does that also always have to be the hair of the same patient, or can you use any hair?
Yes, we have used the hair of same patient many times. Also, we have used any hair many times. And the result was very satisfactory. The hair is pliable and not harmful by any means to the skin, and can accommodate the local edema and help the patient to be meticulous during the repair. I think it's better suture material, and I use it for a huge number of cases.
Yes. And do you need to remove the sutures after, let's say, 10 to 14 days, or do you or are they degraded spontaneously?
Yes, it should be removed, and it should be removed at least. I have left it in some cases up to 2 weeks, more than 2 weeks. But in the usual, we leave it 5 to 7 days, in average 1 week, but should be removed. Yes.
And then do you sterilize the hair before you use it? Do you use alcohol, for example, to clean it?
Yes, we have tried all methods of sterilizations. We use alcohol, we use betadine, we even autoclave it, and I think every method is suitable. Autoclaving it also is better, but we haven't found infection or evident infection, maybe in a few cases.
Okay, thank you very much. And then one final question, maybe. Of course, we all know the reconstructive ladder, and you've explained a lot about flaps. And
Yes.
but you also mentioned skin substitutes in the beginning of your lecture.
Yes.
Of course, I'm intrigued by that. Where would you position skin substitutes versus flaps in your reconstructive practice?
Skin substitute is very vital options. Actually, I mentioned it because it's in the modern plastic surgery as essential part. The issue of availability may be a hinder sometimes, but there is a good result with skin substitute with many other colleagues. If there is a hinder to use a flap, you can use a skin substitute instead. Yes.
Yes, and do you consider it of a higher complexity or lower complexity than flap? Would you rather use a flap than a skin substitute, or the other way around, or does it depend on the case?
Yes, it depends on cases. Skin substitute can be useful in areas that not reach easily by the flaps, or need a huge flap. In the foot reconstruction, it's very useful options also. Materials such other skin substitute material can also be put even in the bone, so it can produce a template of dermis upon which you can put split thickness skin graft, which is I think is technically an easy technique available, and you can do it when flap or surgical procedures is hard to be performed with such some sort of patients. Yes.
Yes, well, thank you very much. I think what we learned both from the beginning and the last speaker in this webinar is that mechanical tension is a key element in scar prevention and scar treatment. Thank you very much again for your very educational talk this afternoon. I would like to thank all the attendants and the speakers and the people who asked questions in the chat. And for now, I have some final announcements. Maybe if you joined us a little bit later, then this might be new to you. We would like to draw your attention to the textbook on scar management, which the Global Scar Society produced 2 years ago, and which is an open access study book on all aspects of scar management, practical aspects, but also theoretical aspects. And then our next event will be the UMA conference, where G-ScarS will have a whole symposium on the 24th of May. And please do join us in Paris, because it will be wonderful to see you all again in a live setting. And then a final announcement. Of course, please do subscribe to the webinars. And our next webinar will be 1 month from now, Friday, March 25th. And that will be on scar mechanotherapy versus bioengineering. And I hope to see you all again there. Thank you for now. Have a good weekend, and I hope to see you soon.